Dr. Gurland, welcome to Ask Ours. You're very familiar with this, obviously. You've been in the field of colorectal surgery for decades now, out of Stanford, very famous, well-known colorectal surgeon. But you've been specializing in pelvic floor, correct?
That's correct.
And you're just coming off of being in charge of the whole pelvic floor consortium?
Yes.
Yes. Can you kind of tell us, what does that mean? What's the focus of it? Why does the consortium exist? What's been the focus? What were you guys able to accomplish in your leadership, and where does it go from here?
So Jeremy, I bet you're not even quite sure what pelvic floor covers and what we do.
Yeah, I'm not sure everything that would cover. There's so much down there. It's one of the most complex anatomies, obviously, to deal with. Yeah. And of course, solving those problems has been a nightmare for the surgical community, for decades.
And for patients.
Yes.
Like, that's the worst part, So for other providers and for patients, and it can be dual incontinence, it can be prolapse, like all those things of aging, and we want to be healthy. But like by the time people, once you head into your 60s, postmenopausal, they'll have 1 or 2 pelvic floor disorders, and by the time at 80, 50% of women have something. So it's a real issue.
Wait, you said 1 or 2 pelvic floor disorders?
Yeah, so under pelvic floor disorders, it can be incontinence, it can be prolapse, it can be, those are the main ones. They can be pain syndrome, sexual dysfunction. In the colorectal world, we deal with a lot of rectal prolapse, and that's a major concern. But also things that are more common, like hemorrhoids and fissures, actually can be masking pelvic floor disorders. So those are like evacuation issues, constipation, that's a biggie that I'm sure people cover. Where they think that it's their hemorrhoids, but actually underlying, they have a fundamental pelvic floor disorder. And so it comes up to the point of the surgeon, is this something that we should surgically correct? Do we need to make more of a diagnosis, do testing? There's a lot of nuancing on it, and you asked me about the Pelvic Floor Consortium. So it's a group of like-minded clinicians, and in that it includes both colorectal surgeons, anyone in the urogynecology or female urology world, pelvic floor physical therapists, radiologists, gastroenterologists, anyone who touches this group is invited as a volunteer. And then we get together and we cover certain topics. This year's topic was something called internal prolapse. Even the terminology was great debate. I mean, and we actually include an international perspective, and they have different perspectives. So what I would say is getting everybody together around a table, simplifying language so that we can improve patient care is important.
Even when you say that, I'm a fully trained surgeon, and I don't know what an internal prolapse is. Like you just said, what does that mean?
What is that? Yeah, what is that?
Can you tell me, what did you guys mean when you say internal prolapse?
Yeah, so there's different kinds of prolapse for any community that's out there. Prolapse can be, for women, can be vaginal prolapse or pelvic organ, which is vaginal prolapse, and then there could be something called rectal prolapse. You may not know anything about it if you don't have it. And that rectal prolapse can be something that stays inside of the canal, inside of the anal opening, but it can extend out. So when it extends out, it's external, and when it stays on the inside of the anus, it's internal. We had a big debate about the language and how we classify it.
And are we seeing any sort of new treatments in this area?
So I would say yes and no, but before I get to that, is it okay if I just sort of classify? The internal prolapse isn't as much as the issue as what symptoms someone's having, like what are they experiencing. People sometimes think they have hemorrhoids, they can have mucus discharge, they can have bowel leakage, they could have defecation issues. I wouldn't say that is specifically a new treatment. I know we all get excited about new treatments, new devices, but it's not that. It's about classifying individuals, giving them the right treatment. There is a surgical procedure that everyone's excited about called ventral rectopexy, but it's been around now for over 20 years, and it's just picking the right patient for the indication or for the diagnosis.
And that's what it really sounds like, even just listening to you. The overlap between the symptomology of all these different things in the pelvis, and how often are we seeing that they're just being misdiagnosed? I mean, they're being reclassified, like a primary care doctor, nothing against primary care doctors or other surgeons who are seeing it, but if you're not really versed in this field, it has to be very difficult to figure out that algorithm to know which one's which. What should somebody as a provider that doesn't focus on this all the time, how should they work through that algorithm?
Oh, it's such a hard question. I don't know that I can answer that. I would say that it's very nuanced. I think that after I'm going to kick in, lifestyle changes have been in place. Like everybody should have conversations around lifestyle, which is going to be their nutrition, their movement, their sleep, any substances that they're doing, any of the restorative, their community. So once you address lifestyle, and then talk also any psychological or stress related things. Once you address that, if they're still having any kind of anal rectal conditions, you've had your primary screening, right? We can never forget cancer. Then I believe that they should be referred on to a specialist, because I don't think I could give you that tips, but I do believe that all medical doctors and individuals, because there's so much content out there now, should be focusing on lifestyle first.
And when you say focus on lifestyle, is this something that you've implemented into your office and your clinic, or?
Yeah, so they have that concept. You have to teach the teacher. So I had to learn myself. How do I modify my own lifestyle? And now that I really tell patients about it. So I will focus on their specific. What is they came to see me because they feel like they have hemorrhoids, but I would still ask them, well, what's happening with sleep, and where are you in the perimenopausal or menopausal status, and what other things are happening? So I do touch on that in my clinic also. Although we're all limited by time and we have to focus on what we want, but I don't think that can be neglected.
And as a consortium, because you said send it to the expert, is it just colorectal surgeons, or do you really want to find that person that specializes in pelvic floor disorders?
So I think that these are siloed together. I think you can refer to a colorectal surgeon, and there's enough knowledge at this point that people will refer on when it's beyond what they know, or that's what I'm assuming. So the colorectal surgeon would be screening them, would do the anorectal exam, and then either they have expertise or knowledge or know what to do, and then they and take care of it, or would refer them when appropriate.
And my understanding is we've yet to find a procedure that's the panacea for this. Let's say prolapse. I mean, as you said,
for anything.
Exactly.
For anything. Yes.
And so, what should the general public, what should the average patient understand if they go to a surgeon's office, and let's say it's not a colorectal surgeon, it's a general surgeon? What should they be aware of to make sure that they're getting asked or getting checked before they are offered some procedure that may be out there?
Well, the more surgery I do, the less surgery I advocate for. So I am only going to offer surgery when everything else has been addressed. So I think for a patient, you have to feel comfortable. You have to make sure that your questions have been addressed. You want to make sure that you're doing all of the things from a lifestyle perspective. And then ask around and look. There's so much content and ways that we can kind of review procedures. So I think that now the information is so accessible that people can really do some research and then find someone that they trust.
Well, absolutely. But you would agree that if you're going in there with a pelvic floor problem,
yes,
the surgeon shouldn't start with, hey, we should just go do this. We should just do this procedure. It shouldn't be the first thing or even the second or third thing off the top of their list.
So I find that an operation alone is never an answer. An operation along with habits and behaviors and really setting expectations is the key to everybody being happy, both the patient and the surgeon.
Are there any other specialties surgeons should be working with in the pelvic floor disorders that they should have good friendships with?
Yeah, so we're a very collegial, lovely group in the first place, but we have really great relationships with either urogynecology and female urology because we partner surgeries with them. We have great relationships with radiologists because there's a lot with pelvic floor imaging. So I would say we noticed that at one of our sessions that imaging really is taking more of a forefront as compared to several years earlier where we were only intermittently imaging. So you should really know or have active open communication with your radiologist. Pelvic floor physical therapists are our best friends. So they work with us on the patients as long as our advanced practice like APPs, advanced practitioners who may be an MP, a PA, who really help navigate patients through. This is a team sport. We had a fabulous talk about that also. So yeah, we have a lot of friends. It's not a single person deal.
When you said increasing the imaging, what imaging are you ordering now?
So we do, so for pelvic floor imaging, it could be pelvic floor MRI, so it's a dynamic imaging. It could be something called fluoroscopic defecography. It could be ultrasound. So there are different modalities that exist. Not one is superior to another. It depends on where you practice, what access to tools you have, and what your provider knows.
And for the surgeons out there that are out, let's say in the areas where there's just not a lot of colorectal surgeons, I don't think that in my region we even have a single physical therapist or any sort of therapist that works with the pelvic floor. What resources would they have, or how would they be able to manage a patient that's complicated like this if they can't? Is there a way to telemedicine? Is there any way to get access to a specialist, at least they can run it by them?
Yeah, so I think we've closed the loop. Like there is more telemedicine that didn't exist, I don't know, 7 years ago, let's say. And the physical therapists were really resistant. Oh my goodness, how can we need to do the exam, where does that fit? But I think COVID helped us change that attitude. There is a ton of content about physical therapy online, but it's hard for people to do it. Like there's a lot of behavior change that it involves. So I believe the content is there, but it's about how you integrate that into your life. So if you have a dedicated practitioner who wants to learn about it, there are opportunities, there are websites, come to meetings like this, reach out to us. So more opportunities exist than did before. The world has become smaller.
Oh, absolutely true. So I want to end with, you've been doing this now for, let's say, a couple decades, and you're seasoned professional. You're
25
obviously
years.
Exactly.
Let's just cut to them.
I think I looked up top 10 colorectal experts in the world, and you were actually on that list. So you were way up there.
I don't know who makes that list.
When we look at it, what is that thing that you've learned that is wisdom, not knowledge? Something you can't find in the textbook, but how you treat your patient, or
it will all be fine. Like it'll like really everything works out one way or another. There's a certain amount of stress that we put on ourselves. If we're talking about for patients, they put on themselves, but actually everything works out. And so for lack of a be silly kind of breathe through it type of deal, I think that people tend to stress themselves out and kind of relive whatever or think, and so not telling people not to think and not to be a little bit stressed, and that means that they care. On the other hand, do you remember the Nemo days when Finding Nemo?
Yeah.
So just keep swimming.
Yeah. Oh no, that's great. That's great. Because you're right, it's amazing how often that you'll sit there and something will happen, and you're like, this is going to be the end of my world, and then a month later you almost, not say forgot about it, but you realize it didn't. The world didn't crash around you.
And I think you could talk about it from the perspective of surgeons and their attitude. You could talk about it from the perspective of patients who are really hyper focused on this is the end of my world. But we create new normals, and so we stress ourselves out sometimes worse than we have to.
Oh, I 100% agree with you. So thank you so much for your time. Once again, I'm sure you're going to enjoy the rest of this beautiful conference out here in San Diego, lovely weather, and I can't appreciate enough for your time on the cutting edge.
Yeah, thanks for having me.